Thank you very much, Dr. Lansman, for your kind introduction. It's a great honor to be in New York City and to present at this meeting. Today, I'd like to speak about our experience with endovascular aortic repair for the type B aortic dissections. We have no disclosure at this presentation. In Japan, the incidence rate of the aortic dissection is 57 cases per million every year. And this rate is over 3 times the incidence rate of the US and Europe. One reason may be related to the ethnicity. This slide shows the treatment strategy for the type B aortic dissection. We normally treat the uncomplicated case with medical treatment and a complicated case with surgery. Acute complicated type B aortic dissection are a good candidate for the emergency surgery. However, how about the uncomplicated type? Here we can see the long-term result of the uncomplicated type B aortic dissection with the best medical treatment. The freedom rate from the enlargement of the aortic diameter over the 60 millimeter was about 60% 5 years from the onset. And it is alarming that over 40% of the patients need surgery within 5 years. You can see the long-term outcome of the chronic aortic dissection in this slide. Aneurysmal diameter length was becoming expanded, and the aneurysma involves the visceral arteries of the abdomen. Finally, the true lumen has become narrower, and we are forced to perform the graft replacement for the entire aortic aneurysms. It is a miserable fate. The treatment of the type B aortic dissection is no easy matter. In fact, there is what we might call a mighty wall in front of us as far as successful treatment is concerned for the type B aortic dissections. So we needed to set up 2 goals to achieve the satisfactory outcomes of the treatment of the aortic dissections. Goal 1 was to investigate and confirm the predictive factor of the aortic enlargement. And goal 2 was then to develop the new, less invasive procedure for the type B aortic dissections. For goal 1, we obtained the predictive factor of the aortic enlargement in the chronic phase as a way of the retrospective study using the multivariate analysis. And aortic diameter larger than 40 millimeters at onset was a predictive factor for the aortic enlargement from this multivariate study. So we divided our cases between the maximum aortic diameter at the onset larger than 40 millimeters and less than 40 millimeters. Freedom rate from aortic enlargement of the less than 40 millimeter group was significantly higher than the larger than 40 millimeter group. This means that the patient who had over 40 millimeter aortic diameter at the onset needed to have a surgery even though they are uncomplicated type. Thus, we try to seek and develop this less invasive surgery for the acute type B aortic dissection, named endovascular aortic repair. We first made the aortic dissection on dock in 1990, and handmade devices were deployed to close the entry. After 6 months, we checked for the condition of the dissection. This entry had closed and the fourth lumen had thrombosed, as shown in this slide. We therefore began the clinical use in 1993. For clinical use, we made our own made stent graft using the polyurethane graft and the Z-stents. This stent graft is one of the devices we made. We further performed some modification of our own made devices as shown in this slide. Until now, on-made devices were necessary, while we could use the stent graft as ready-made devices, there is not yet any suitable devices for the aortic dissections. Indication for the TIVA at our institution for the type B aortic dissection included a complicated case, for example, the aortic rupture and malperfusion, and the aortic diameter over the 40 millimeter at the onset of the dissection. In addition, the aortic diameter dilated over the 50 millimeter during the follow-up, and rapid enlargement at least 5 millimeter within a year. Our treatment strategy for the type B aortic dissection is an all-entry closure in the thoracic aorta with minimal coverage using a short device. And also for the preventing the retrograde dissection after the TIVA, we have to use non-dissected area for the proximal landing zone. From 1993, we performed 2,143 aortic surgery with the stent graft. Out of all aortic surgeries, for the aortic dissections, we performed the TIVA, including the hybrid procedure, in 506 cases. 79 cases are acute and 427 are chronic. First of all, I would like to speak about the acute type B aortic dissection in 79 cases. The mean age of this study was 63 years old, and the period from the onset to TIVA was 5.8 days. We used several devices. In this study, we performed debranching TIVA in 29 cases. Here we can see the early result. The primary success rate is 97%, and the hospital mortality was 2.5%. There were few postoperative complications. After the TIVA for the acute dissection, the status of the false lumen is very, very important. Half of the patient had the shrinkage of the false lumen, and the quarter had the disappearance of the false lumen. With the other quarter had no change of the CT level of the left atrium. There was very few cases in which the enlargement of the false lumen occurred. Freedom from the aortic event was 79% in 3 years and 73% in 5 years. 9 cases appeared to have had an aortic event. I would like to show you the risk factor analysis of the aortic event in this study. The Cox proposal hazard model was used to identify the predominant predictor for the aortic event throughout the follow-up. Aortic angulation and aortic remodeling at 6 months after the TIVA had a high correlation to the late aortic event. And here is a graph that shows the correlation between the distal angulation and the oversize of the devices. The red circle shows the melting of the distal side of the devices at the aortic event. And the blue circle shows the floating of the devices. Both aortic events occurred in case over the 20-degree angulation at the distal side. So that we understood the need to deploy the devices at the straight portion at the distal landing zone. At 6 months after the TIVA, 65% of the cases had aortic remodeling. So that we divided the patient into the 2 groups by the presence or the absence of the aortic remodeling. Freedom rate from the aortic remodeling of the aortic freedom from the aortic event of the aortic remodeling group was significantly higher than that of the non-remodeling group. Next, I would like to speak about chronic type B aortic dissections. After the 427 chronic type B aortic dissection, 3/4 was a male, and the mean age of the patient was 65 years old. And there was some preoperative complication, as you can see here. In order to treat these patients, we perform two different kinds of procedure. When there is an appropriate landing zone below the left subclavian artery, simple TIVA was performed. However, when there is no sufficient landing zone, we perform the one or two cervical debranching TIVA. We have used several kinds of devices, and recently I think Goa C-tag and Bolton relay NBS Plus are becoming the suitable device for the type B aortic dissections. Here are the early results. The primary success rate was 98% and the hospital mortality was 2%. And there are a few postoperative complications. I would now like to show you the long-term result. The mean follow-up period is 83 months and follow-up completion was 95%. Overall survival rate was 83% at 5 years, 77% at 10 years. Freedom rate from the aortic event was 80% in 5 years and 68% in 10 years. This is the key slide in this presentation. We divided the patient who received the thin slice MDCT from the 2005 into two groups with 9 months from the onset to the TIVA being the criterion of the division. The group within the 9 months from the onset had a significantly higher freedom rate from the aortic event than the other group of the over 9 months. From this result, chronic type B aortic dissection within 9 months from the onset looked like being a good candidate for the TIVA. Then I would like to recommend you to take into consideration the following factor when you perform the TIVA for the acute type B aortic dissections. The first is deployment of the devices at the non-dissected area for the proximal landing zone at a straight portion for the distal landing zone. The next, need for the careful observation for the patient who had not had aortic remodeling at 6 months after TIVA. And finally, I would like to recommend the device companies, please make a good device for the aortic dissection which have excellent flexibility and come in a multitude of the variation, including a taper graft and no bare stent of the proximal zone. I believe that we are able to win the aortic dissection fight as we come into the new era of the endovascular aortic repair. Thank you very much for your time and attention.